we'll move on to the orations. Now the first oration is Dr. Rednam Surya Prasad Rao's oration. Rednam Surya Prasad Rao was the student of Andhra Medical College, and he was the professor of ophthalmology in Andhra Medical College, and he is basically from Visakhapatnam, belongs to the Rednam family, and his son and his nephew, many of them are the ophthalmologists who have had significant contribution to the field of ophthalmology in Andhra Medical College as well as in Visakhapatnam, city of Visakhapatnam. On his name, we have installed an oration. He is a great teacher and a very good clinician. So this award we generally select to the teachers in the medical colleges. So this year we have identified Professor P. Prabhakar Shastri. Now I invite Prabhakar Shastri please to come onto the dais. So to introduce, please take your seat, Prabhakar Shastri. Dr. Prabhakar Shastri was born at Vijayawada. He completed his school and college education in Vijayawada itself. After completing the MBBS from Andhra Medical College, Visakhapatnam, did his post-graduation MD Ophthalmology from RP Center, AIIMS, New Delhi. He was with Professor Madan Mohan for nearly 6 months to learn about the corneal surgery, especially keratoplasty. He worked as fellow and medical officer at Aravind Eye Hospital Postgraduate Institute in Madurai. He joined in Medical and Health Services of Andhra Pradesh in the year 1994, worked as a professor at Siddhartha Medical College, Vijayawada, Associate Professor, Rajiv Gandhi Institute of Medical Sciences, Ongole. Presently he is working as a Professor of Ophthalmology, Government Regional Eye Hospital, Andhra Medical College, Visakhapatnam. He did his FACO Fellowship from Shankara Eye Hospital, Guntur. He has presented several papers in national and state ophthalmic conferences. He is a life member of All India Ophthalmological Society and Delhi Ophthalmological Society and AP Ophthalmological Society. Prabhakar Shastri is interested in teaching ophthalmology and serving community by conducting eye camps in rural villages. His hobby is to play flute and then read books. With this introduction, I introduce Dr. Prabhakar Shastri to the audience. And now I invite Dr. Prabhakar Shastri to deliver his oration.
Good morning, all of you. At the outset, let me thank the organizing committee of APOS and the AOS for giving me the opportunity of delivering this prestigious Dr. Rednam Surya Prasad Rao oration. Even though I'll be talking about a small topic, it is definitely important to know something about this corneal graft rejection. Just to reduce the corneal blindness. So, and if you see the out of many causes of the blindness, corneal blindness is one of the leading cause of blindness in the world. And according to the WHO reports, the whole world population is suffering with 5% of corneal blindness. So this is the report from the WHO, and these are the causes of important causes of the corneal blindness, and out of which the bullous keratopathy, aphakic bullous keratopathy, pseudophakic bullous keratopathy, or post-operatively, they are all iatrogenic causes, and the other causes for corneal blindness is like corneal opacities, dystrophies, corneal injuries, and then congenital abnormalities. So this is the list of the corneal blindness, and definitely it constitutes one of the the important causes of the total blindness. And to combat this blindness, if you see the statistics, there are around 40,000 ophthalmos all over approximately all over in India, and there are 764 eye banks, and the only functioning eye banks are around 220. So the corneal blindness is heavy, and if you see the figures, statistical figures, 68 lakh people are suffering with corneal blindness, and in that at least 11 lakh people are blind bilaterally because of the corneal diseases. So on an average, 40 to 50% of the corneal donations are used for transplantations, and more than 1 lakh corneal transplants are required in India annually. Whereas the corneal transplantations are done every year, we are doing only approximately 25,000, and 30,000 eyes are collected every year. So the demand is more, whereas the supply is less. So the current annual transplant, as I told you, is only 25,000. 30,000 new cases of corneal blindness are added to the burden, and nearly there are around 1,000 corneal surgeons are there, and out of which only 400 are involved in the grafting work. Now I will go on to the subject proper, that is corneal graft rejection and failures, and we have to understand what is definitely the difference between corneal graft rejection as well as the failure. By definition, corneal graft rejection is an active process wherein there will be a complex immunological reaction from the host antigens against the donor corneal tissue, ultimately leading to decompensation of the cornea. The grafted cornea should be clear for at least 10 to 15 days to say it is a corneal graft rejection. Otherwise, by definition, you cannot say. Immediately, if you see post-operatively, whether it's corneal edema on the day one, we cannot label it as a corneal graft rejection. So, once if there is failed cornea, it is failed forever. Whereas a corneal graft rejection, if you treat it at a prompt time, prompt treatment and then correct treatment, it will definitely go back to the normal stage, clear cornea, whereas unlike the corneal graft failure, once if the graft is failed, it is failed forever. And by definition, if you want to know what is graft failure, primary graft failure is defined as corneal edema that never clears from the immediate post-operative period secondary to inherent deficiency in the donor graft or surgical trauma or during transportation and improperly stored tissues. So this is the definition. It's not related to corneal graft failure, is not related to graft rejection. This is something different, whereas graft rejection is an immunological reaction. All these human organs transplantations are governed by an act, we call it the Human Organ Transplantation Act, established in the year 1994 by the Government of India, and it covers all the ethical aspects, social, financial, and humanitarian aspects of the organ transplantation. And the Government of Andhra Pradesh has started this Jeevan Daan program, which includes also this cornea. And this is in general the types of grafts. Of course, all of us know that there are 4 varieties. Autograft is within the same individual, isograft between the twins, and then allograft is from the same species, another individual, xenograft is different species. These are the 4 varieties. But we are concerned with the corneal types of the corneal graft rejection. Before that, I want to tell about the types of keratoplasty. Basically, there are only 2 varieties of corneal grafting, full thickness keratoplasty and lamellar keratoplasty. For the last 2 decades, there are so many advances in the lamellar keratoplasties, namely deep anterior lamellar keratoplasty, Descemet stripping endothelial keratoplasty, and you have DMEC. Right, just now Dr. Basak has told DVEC and then DSS, so many advances. See, layer by layer, the cornea is being taken and it is given to the needy patients. Whatever tissue is needed, that is taken and then transplanted to the needy patients. So this type of component keratoplasty has given a wonderful success rate for the corneal transplantations, unlike the penetrating keratoplasty. And in general, these are the types of graft rejection. You have hyperacute and then acute, chronic. This is in general. But as far as the corneal graft rejection is concerned, you have basically epithelial rejection, chronic stromal rejection, hyperacute stromal, chronic focal endothelial, and combined stromal and endo. You have a combined type of rejection, including all these layers. So this is the types of corneal graft rejections. Little bit about the characteristic features of the rejections. Epithelial rejection, you can this slide is showing the junction between the host and graft, and the epithelium is, if you observe this epithelial rejection, the epithelium is hazy with little infiltrations, and some spots are there seen in the between the subepithelial layers, and they are called as KS spots. Here the slide is showing the host graft junction, and the another one is stromal rejection. The stromal rejection is characterized by the infiltration of the antestroma or deep stroma, and these lesions just mimic the adenoviral lesions, just the lesions of the adenoviral or any other herpetic lesion. There is a similarity between these lesions and then stromal rejection, but of course it is a immunological reaction. This, if the stromal rejection is superficial, it may not lead to a rejection, but if the entire stroma is involved, it can definitely lead to graft failure. And you have hyperacute stromal rejection, and this is characterized by a layer of haziness advancing to the center of the graft through 360 degrees slowly, involving the stroma, and it is having a special features like sometimes it may be looking just like the corneal abscess because of the severity of the rejection. And finally you have endothelial rejections. So endothelial rejection is characterized by an advancing line, which is nothing but the lymphocyte and the immunological cells involved, and you have a clear cornea between the advancing line and then the other part of the donor cornea. The same thing, endothelial rejection. And here are some slides showing the various varieties of graft rejection. This one is the initial stages of the epithelial rejection. You can see at the host graft junction, the suture tracts are having some whitish spots, and this is the leading part of the immunological reaction. And this slide is showing the subepithelial infiltrates. This is endothelial rejection. We call this line as a Codeoblast line, and it's nothing but graft rejection line advancing toward the center, and at the periphery you can see the new vessels coming onto the cornea and progressing towards the center. And this is another slide showing the same thing. And subepithelial spots, they are called as Crackmer spot, nothing but cell infiltration, immunological cell infiltration subepithelially. As this is the most worst case of the graft rejection, showing the keratic precipitates at the back of the cornea endothelium, and there is aciflarent cells. The entire cornea is going to be rejected soon in this case. So this slide showing total graft rejection, and this one is the endothelial line, the rejection line. Sometimes you can see a combination of all these things, endothelial rejection as well as the stromal and then the epithelial rejections. This is badly rejected cornea, full thickness involving all the layers. As I told you, the difference between the graft failure and graft rejection. In the graft failure, there will be edema maybe from the first day, second day. This is one of the slides showing the graft failure, corneal edema not resolving, and then later leading to corneal decompensation. This is a badly spoiled cornea with vascularization. You should not take this for corneal grafting. It's a high risk case. Now, why the cornea will get rejected? If you see, you can divide the risk factors into donor factors, host factors, technical factors, and then sometimes the post-operative factors can also lead to graft rejection. Or you can also divide the causes or risk factors of graft rejection is like preoperative, postoperative, and then paraoperative. Like that you can divide, and the details of these risk factors. As far as the donor tissue is concerned, you have say donor factors having, suppose if there is antigen overload or the histo incompatibility as far as the HLA and ABO blood group is concerned, even the gender is also involved, duration of the tissue storage, the technique of the taking corneal button, and then the vaccination status of the donor, all these things matter. And the host factors, many causes are there where the cornea get rejected, and the examples for corneal factors are like vascularization of the cornea, as I showed you in the previous slide, and the regrafts or failed grafts is other risk factors. And the other risk factors as far as the host is concerned, you see the patients who have undergone excimer lasers, ABO incompatibility, or the people are having ocular surface disease like dry eye, chemical injury, Lyme injury. All these things are very risk factors for the development of corneal rejection. Some more risk factors, the patients are using pilocarpine or having uncontrolled glaucoma, undergone large ag laser capsulotomy, and the large grafts, interstitial keratitis. Again, they are all the predisposing, the risk factors for the corneal graft rejection. Sometimes even the eccentric grafts, large grafts, presence of Fantasynicae, bilateral graft, loose sutures, previous anti-segment surgeries, they are also the risk factors for the development of corneal graft rejection. Post-operatively irritating exposed suture edges, and if there is some blepharitis, trichiasis, entropion, and then the vascularization, all these are also post-operative causes for the development of corneal graft rejection. So all the risk factors are tabulated here. Just now I have covered all the risk factors, and as far as the risk is concerned, corneal graft risk, it can be divided into low risk, high risk, and then medium risk. High risk the patients say will be having the diseases like if the cornea is exposed for the chemicals, and if the cornea is having the viral keratitis, vitrectomized patients, active keratitis, and then the keratoplasty in children, they all come under high risk corneal grafting, whereas the graft will be very nice and clear in case of low risk factor like corneal dystrophies, keratoconus, and central cornea without any vascularization. So you can preoperatively you can check definitely whether some patient is going to have high risk graft rejection or low risk. This is another tabular form depicting all the risk factors of graft rejection as well as graft survival. Now, so it is important to know the signs and symptoms of graft rejection. Not only the doctor, the treating doctor, even the patient should be educated regarding the signs of rejection, and we have to educate the patient so that he can come at an early time for the treatment, so that we can give a good treatment, and we can definitely give a clear cornea. Patient compliance, patient follow-up is very important. As far as the symptoms are concerned, regarding the graft rejection, there will be redness, pain, photophobia, and then diminution of vision. And as I showed you in these slides, the several signs you can see, if not in the initial stage, maybe after some time of the graft rejection, you can see the signs of the graft rejection like chemosis, conjunctival congestion, ciliary congestion, raised intraocular pressure. We can see stromal and subepithelial infiltration, endothelial rejection, and chordodust line. Now, coming to immunopathology, this is cornea is very tricky tissue as far as the immunopathology and the immunopathology of the graft rejection is concerned. We all know that the cornea is not having blood vessels and not having lymphatics, and it is having a special soluble proteins we call it echoid anti-chamber associated immune deviation. They are all helpful for not developing the immunological reaction, all these things. Despite of all these things, some patients will develop graft rejection, and these are the, of course, it's very difficult to remember all these names of the complement cascade of reaction in immunological process. But if you go through the cellular immunology, definitely you will understand. And as I told you, despite of the presence of all these things, echoid vascularity, and then the lack of lymphatic, some grafts will get rejected. And the reason being, now if you see the pathophysiology, after some time of the grafting, there will be, say around 2 months, 3 months, there will be slow development of the vascularization. Through the vascularization, the immune cells will come onto the donor cornea, and there happens antigen and antibody reactions. And especially the major histocompatibility class 2 antigen and are related to immunological rejection of the graft. CD4 cells, CD8 cells, they get stimulated, they go to the lymph nodes, and there the memory comes to these cells, the immunological cells, and they again they enter into the blood vasculatures, and it is a vicious circle. After sometimes maybe around 3-4 months, sometimes it may be even 1 year for it takes 1 year for the graft rejection. So if you understand the process of graft rejection, definitely we can treat at the beginning stage, or as you can after some time, even at the end stage also you can try with the latest drugs. So this is a clear graft, this is a failed graft, of course, and some diseases just mimics the corneal graft rejection, namely a late graft failure and sterile endophthalmitis are examples for the differential diagnosis of graft rejection. We will think that it is a graft rejection, but it is something different, like epithelial downgrowth, recurrent herpetic keratitis. They all come under differential diagnosis. They are really they are not the features of the graft rejection. There is a differential diagnosis. Now let us see something about the final part, that is the management of the corneal graft rejection. And see, all the studies we have comes from the registries like Australian Corneal Transplant Registry. They are retrospective studies, Singapore, UK transplant studies, and you have corneal transplant collaborative studies, and then corneal graft rejection treatment follow-up studies. Now, the most important factor regarding the management is, like, you have for a routine graft rejection cases with a low risk, you can start with the local steroid like prednisolone drops and dexamethasone, and even systemic steroids according to the body weight. And if you think the graft rejection is very high, severe, you can go with IVMP, methylprednisolone pulse therapy. And later on, we can try the combination of steroids with cytotoxic agents like azathioprine and cyclosporine. Newer modalities have come in the management of the corneal graft rejection, severe graft rejection. Apart from the cytotoxic agents and then steroids, people are trying with the tacrolimus, 0.6 milligrams kg body weight, both the drops as well as the ointment forms are. The other drugs are like ripamycin, deoxyasparagine. These are all the drugs used for preventing the corneal graft rejections. The latest one is cord blood stem cell culture. Human organs are tried for the replacement of the epithelium and then the endothelial cells with the help of cryobanking, bionic organs. And to summarize, recent invention, the component layer by layer corneal lamellar keratoplasty has revolutionized the success rate of corneal transplantation. With the corneal component layer by layer surgery, corneal graft rejection rate has come down to 0.1 to 0.5. And some other the modalities of treatment, even before the surgery, UV light treatment of the cornea, and then the tissue cultures, epithelial and endothelial cultures are used, pachymetry, and as I told you, the tacrolimus and cyclosporine drugs are used for the prevention of the corneal graft rejection, apart from ripamycin and DSG and Segra. Anti-VEGF drugs are used for preventing the vascularization, like bevacizumab, once if there is, the surgeon notes vascularization of the periphery. So thank you one and all for your patient listening and kind attention.
Now I request Dr. G.R. Reddy and Dr. V.V. Alansar to please come and then hand over the plaque to Dr. Prabhakar Shastri. I request that our scientific committee chairman Madhu also please join.
So the next oration in the APOS is Dr. Malleswara oration, and this year we were proud to give it to our Dr. Vasudev Palimar sir. So he could not attend this meeting, but still we honor his services to the community, and especially these 3 districts, the services he has rendered, especially in vitreoretina. If you see 20 years back, thinking of starting a specialty practice, that too in retina, was unheard of. I think so many patients were restored vision because of his active intervention. And Dr. Palimar Vasudev earned his MBBS degree from Andhra Medical College after he topped the MSET exam in 1980 and received 2 university gold medals. He pursued his MD in ophthalmology in the esteemed All India Institute of Medical Sciences, and he was there where he met Dr. C.V. Gopal Raju sir, and there they started the journey together. After he joined his residency, he was captivated by the wonders of medicine and its ability to restore sight in ophthalmology. This fascination led to him to deep dive into the realm of vitreoretina surgery at Aravind Eye Hospital, Madurai, where he gained his invaluable training under the guidance of legendary Padma Shri Dr. P. Nam Perumal Swami Garu. Before establishing Vishaka Eye Hospital in 1992, along with Dr. C.V. Gopal Raj Garu, he worked as a consultant at Aravind Eye Hospital. Today, Vishaka Eye Hospital has grown to encompass 3 branches and serves as a center for postgraduate education. The hospital has the distinction of being the first in the region to introduce laser treatments and vitreoretinal surgeries. Dr. P. Vasudev embraced new technologies, often daring to tread the path that was feared, and he ventured into it. Today, it possesses cutting-edge equipment for digital visualization of surgeries, eye surgeries, making it the sole facility in the entire Andhra Pradesh to possess such technology. So on behalf of Vasudev sir, I request his close friend and partner, Sri Gopal Raju sir, to take this award on his behalf and speak a few words also.
Actually, we are asking Vasudev for this award since a very long time, and every year he used to refuse. Then we said, no, this time you must get and you must take. And actually he was forced. Then only he accepted. Otherwise he should have got long back.
Dr. Vasudev, I think everyone knows about him. He's a little shy, and then generally he's very much into the academics and then the clinical care. He's a wonderful clinician, and I have learned many things from him. So I was the biggest beneficiary of this association, and right now he's doing well, but as I said, he's a little shy, so and he had recently some health issue, but he's recovered now, he's doing well. So ours, I can say proudly, this is the longest association, successfully running almost for the 3 decades, more than 3 decades. And it's mainly because of his nature and also the frequency, the wavelength we both have, the main reason for this successfully running into these decades. And today, I think all the 3 orators are from RP Center. This is not, don't blame me, I am also secretary from the RP Center. But this was just a coincidence, it's not any other thing. Now I request Dr. G.R. Reddy to please come and then occupy the stage, conduct the proceedings for the Siva Reddy oration. Professor Siva Reddy, I think everyone knows very well. So he was one of the earliest pioneer in many of the cataract procedures or refractive surgery. In those days, he used to do the blade with radial keratotomy and published several things, several articles. And even from the remote, distant place, so he was the president, surgeon for the President of India. And then he used to command a lot of respect when I was doing the post-graduation in All India Institute. If he comes from the Hyderabad, chief of RP Center also used to receive him and then accompany him. So such a kind of a wonderful person of Professor Siva Reddy sir. And he was the founder of this Andhra Pradesh Ophthalmic Society. And he used to attend almost all the meetings and he used to meet everyone. And then he was a great teacher and a good clinician. So that is all about the Siva Reddy sir. This year we were grateful and thank you Professor Titiyal sir for accepting. Now I request our scientific committee chairman to accompany and request Titiyal sir to please come and occupy your chair on the dais. So to introduce Professor Titiyal sir, today's Siva Reddy orator, I think I was the fortunate student of the Professor Titiyal. He was when he was a senior resident, and then I was the junior resident. So I learned many things from him. So he was now the chief, and yesterday only the good news or this new achievement of becoming the Dean of All India Institute of Medical Sciences Academics. So congratulations sir. So, and then what a coincidence, and we are very fortunate to you to be here. He has several publications and then he trained several students, and then for that he awarded Padma Shri Outstanding Contribution in Medicine in 2014 itself. So he has several international awards, Distinguished Service Award from Asia Pacific Academy of Ophthalmology, Senior Achievement Award 2016 in American Academy of Ophthalmology, and then APCARA's Certified Educator, then Certificate of Excellence, ICL User, Certificate of Appreciation of International World Ophthalmology Congress in 2012. And from the community, and he has several awards from the academic side, community service side, like that. So there are many things. If we will go and read, I think this day will not be sufficient. So to mention few, Sarvepalli Radhakrishnan Memorial Award and other administration as the President ISCARAS Society, President DOS, then Chairman National Eye Bank, Secretary DOS. Earlier he held those administrative positions. So very rarely we see a people like both administration and then academics and then a teaching ability. With these words, now I introduce Professor Sityal sir to this august audience. Now I request him to deliver the Professor Siva Reddy oration.
Good afternoon, friends. Namaskar to all of you. Indeed, it's a great honor to be here in this Andhra Pradesh Ophthalmic Society meeting, and especially thank you, Dr. Reddy, the President, and my own Dr. C.V. Gopal Raju, and Dr. Madhu for a kind invitation. And it's a real honor to deliver this oration on Professor P. Siva Reddy, who's been a great clinician, teacher of our ophthalmic fraternity in this country. And today, sitting in the audience, Dr. Chandrasekhar, who's received Padma Shri last year, and it was a great honor to listen to you, sir, and very motivating. And I had a pleasure to write a brief few notes when you received Padma Shri as one of the awardees at that time. Congratulations, sir, doing such a wonderful work for our country, which is really needed for not only for a country, but all population which are there in a area which is totally deprived of these facilities. Today I'm going to talk about something which we are working on, and we have worked for last so many years to improve the outcome of surgery, that to a cataract surgery in Indian population, not for India, world over. I think this is one surgery which can really change the outcome of a particular suffering, disease of a person. You can improve the quality of vision. You can improve the quality of life of a person after doing cataract surgery, because a person who's suffering at the age of 60, 70 can become as young as 20 years because of a modernization in cataract surgery and intraocular lenses. We talk about cataract surgery in such a large extent. Today we talk about giving a vision which is as good as refractive surgery in the cornea, or a correction of refractive error in a patient. So we have to really work in such a manner where outcome improves to that extent where you hardly have a complication, and implant the intraocular lens in such a manner where things can improve. So what better can happen if you can image the entire clinical aspect of a cataract, a patient, and do a clinical assessment through imaging during the cataract surgery also. No financial interest from my side for this talk. We all knew how to examine your patients, especially the cataract patient, where examination under slit lamp is the teaching for all of us, which gives you so many details. Like this is one example of a senile cataract, intumescent cataract. You can see the bulging of anterior capsule. You can see shallow anterior chamber. You can see intralenticular clefts. These things can be appreciated in imaging also, because imaging is the authentic, you can say, reporting of a particular system or organ or a disease area, and that is what you see, and can be a real good impression for yourself or patient for recording also. The same picture can be seen in the intersegment OCT also. But what is missing here? This image is not a live image, it's a still image for a case. And what better would be there if you do a imaging when you do a surgery also. And that has been possible now with microscope which are integrated with optical coherence tomography system. So these are called IOCT microscope, where you can see the entire dynamics of a surgery. You can see what happens to the tissue, a part of a eye where you actually do a particular step of surgery. Incision, capsulotomy, nucleotomy, implantation lens, posterior capsular delineation, the wound delineation can all be appreciated in a very dynamic fashion during your surgery also. The entire visibility can be totally different than what you see through the microscope, which gives only 2D images. To see a 3D images, you require an IOCT microscope. So today I'm going to take you through the two difficult areas or challenging situation in cataract surgery. You all understand wide cataract does give you challenges, poor red reflex, shallow anterior chamber, intumescence, chances of rhexis getting extension to periphery is very, very high in intumescent cataracts. Therefore, imaging, as I showed in the initial slide, where you could do a very nice examination before surgery by doing anti-segment examination by slit lamp, anti-segment OCT. Same can be picturized on the table in IOCT microscope. So these are various spectrum of wide cataract imaging which we have titrated, seen through the microscope to see and classified them in 4 different types. And you can have a spectrum in between also. These are 4 categories of a white cataract, which I'll describe how we have done it. There are 2 things. One is the examination through anti-segment OCT or slit lamp. The green ones, the convexity of anterior lens capsule, the arrangements of lamellar cortical fibers, the lenticular cleft, they can all be seen. But what you can see through IOCT microscope is what happens, the flattening of anterior lens capsule when you inject the viscoelastic in the anterior chamber. When you make a nick into anterior capsule, what happens to the entire dynamics of capsule? Does it go flatten? Does it get raised? What happens to the fluid coming through? All these can be seen with a one step of surgery through IOCT microscope. Type 1 white cataract we classified into a very regularly arranged lamellar fibers, minimal intralenticular clefts, and the convexity is not much also. If you make a nick also, nothing comes out. Everything is flat. You can do a nice capsular access, finish your surgery without any difficulty also. We categorize this type of cataract, white cataract, into type 2 intumescent white cataracts, where you had an increased convexity of anterior capsule. You had a thick sheets of a cortical fibers, hydrated one, and intracortical fiber clefts, which are underneath these hydrated cortex. If you make a nick here and release nothing comes out because the fluid pockets are inside the hydrated cortical fibers. And these cortical fibers, they raise like a dome or like a tsunami. If you don't control your surgical step at this stage, the capsule is going to tear to the periphery 100%. So you have to do very small rexes, and these cases can be managed effectively if you do this technique also. This is the example of a type 2 cataract. You can see as soon as I make a nick, entire cortical fibers are getting up like a hill, and this has a tendency to pressurize the capsule and tear will go to periphery. So we have to tamponade the peripheral area, make a small opening in the anterior capsule, aspirate this cortical fiber, not the fluid, cortical fiber, so that you decrease the pressure, make the convexity into concavity, so that subsequently you can tear the capsule very effectively without risking your capsule to go to periphery and complete your phaco surgery in this case. Type 3 is a mixture. You have a hydrated fibers also, you have a fluid also, and when you actually make a nick, sometimes a turbid fluid comes out, sometimes milky fluid comes out, but mostly it is a very light, oily fluid coming out, which per se will decrease the pressure, intralenticular pressure, and you can still do a surgery effectively in these cases also. So these are cases where needle aspiration might help you. The previous case, type 2, needle aspiration doesn't help there because it's a cortical fibers. So you have to actually aspirate with the aspiration methods. This is a type 4, which is totally fluid. We call hypermature cataract or Morganian cataract. You make a nick, and entire fluid comes out and pressure goes down. You can do a nice capsular access subsequently also. Femtosecond laser devices have come in last 15 or 20 years, and that also gives you a nice assessment through OCT, which is there in a femtosecond device also. You can see here, you can pixelize the entire cataract. This is the fluid-filled pocket which is there. And this fluid-filled cases give a different challenge in the femtosecond laser. You can see now, this is called a bursting of fluid coming underneath the capsulotomy. These cases can be difficult sometimes. We have to stain them, see the area, skip areas, and manage subsequently. So if you're doing manual surgery, and if you're doing femtosecond surgery, they are totally 2 different ways to understand these cases per se. So this is how we classified the challenges faced. We know that type 2 may not be amenable to needle aspiration, which we classically teach everyone. If you have an intumescent cataract, aspirate the fluid. So not all cases will have fluid. They can have a hydrated cortex, which may not come with a needle aspiration. So you have to see your patient carefully. I know that many of you will not have access to IOCT microscopes. But what I have shown, that can be translated to your examination of your cases with slit lamp and anti-segment OCT also. So this is what we teach nowadays. If you see a white cataract, always do good examination, perform anti-segment OCT, and if you have IOCT, that will definitely change your concept of surgery during the each steps and manage these cases accordingly, whatever you face during the each step of your surgery. The white cataract is challenging, but it can be managed effectively if you can structurize or picturize the entire morphology of your cataract. Second challenging aspect will be a posterior polar cataract, because we do see posterior polar cataract, maybe 1 in 100, maybe 1 in 500 in busy clinician practice. These always have a different presentations like this, multiple presentation there where you may have different challenges. So this is a two-dimensional picture. You can't see what is the status of a posterior capsule in relation to the posterior polar disc. So that can only be seen by anti-segment OCT, which is either the your pre-surgery or intra-op OCT or a femtosecond laser device. So this is what you see. You can channelize your examination into seeing the posterior capsule and the disc as such a posterior polar cataract. So these cases can be pixelized. So this is one publication, I think one of the best publication we have in the posterior polar imaging by one of my colleague, Dr. Amar Pujari, where we have delineated the high-risk features or images on anti-segment OCT of these posterior polar cataract. So these are three important images which you can see through the anti-segment OCT, or sometimes you can see with the slit lamp also. The first one is a conical shape, second is a moth-eaten appearance, and third is the eclectic morphology. If you have these three types of morphology, you have a very high percentage chances of a posterior capsule getting opened up during your surgery, and your entire surgery will get messed up. So this is what you have to see. Accordingly, you have to change your surgical pattern, modify your phaco parameters, and do surgery effectively with these patients also. These imaging which I am talking about is not only for phaco surgery. These are important for all types of cataract surgery. It is important for SICS also. There you can modify your surgery accordingly. If you are generalized morphology, you have very less chance of posterior capsule getting opened up during your surgery. So this is very important feature of posterior polar cataract which you have to assess. Same time, we also publish our examination of these cases through intra-op OCT also. There also we could pixelize the similar patterns, and we classify them to 4 types of different cataract based on a clear delineation of posterior capsule underneath the disc and the size of disc as a type 1, where you could see the posterior capsule clearly, and surgery becomes as simple as routine surgery because the PC is clear. You can do hydro procedure effectively in these cases, and surgery becomes very simple here. You can see this is one of the first time you will see that actual separation of fluid happening by hydro procedure. You can see here, now I'll inject the fluid. You just see the IOCT picture. You'll see the fluid wave creating space there. So you have endonucleus and the epicortical cushion. You can customize the cushion for your safety for your patient as you do in a femtosecond laser in these cases. So that is the advantage of knowing what is happening during your surgery with the IOCT microscopes. And these type 1 cases you can do very effectively. This is type 3, where you have a moth-eaten appearance. The entire disc is very, very large, thick, and you have absolute shadowing. You can't see the posterior capsule at all. So these cases are very high chances that posterior capsule can get opened up. There you require a technique of doing nucleotomy where you safeguard the posterior capsule, because sometimes the posterior capsule will be open, or sometimes it might open during your procedure of hydrodissection delineation. The nucleotomy has to be absolutely safe. So this is what we published recently in IGO. The video is available there. People can see there how to do a safe nucleotomy, that is chop and tumble technique. Do a first delineation, one delineation, second delineation, and you'll see that this delineation can effectively translate into 2 separate compartments, endonucleus and epicortical cushion, and subsequently you can do surgery in these patients also. So how to do surgery without rotation? Because rotation is not applicable in a posterior polar cataract, sometimes in a slightly harder nucleus. So do a first chop here, because you can't do rotation because delineation not complete. Take another chop here, take out this piece. So this gives a space for a fluid to go, give internal hydro delineation happening in these cases. Again, second chop, now I can tumble this piece to the center with my second instrument without disrupting the epicortical cushion. I think this is a very important teaching for all of you to understand difficult cases like a subluxated posterior polar cataract or a post-vitrectomal eyes where you might not be able to rotate nucleus, and do a safe chop and tumble technique, and that will give you access to a nice outcome. This is to represent same surgery with IOCT pixelization, how the fluid goes inside and separates the layers of epinucleus. You can see the various area of separation happening because of IOCT imaging in these cases of posterior polar cataract. And this selective dislodgement of a nucleus from the epicortical cushion without disrupting the epinucleus core is very important for not only for posterior polar cataract, cases with open capsule or patients with subluxural cataract also. So this is one case. You can see IOCT microscope shows that this is a conical shape or may have an open posterior capsule in these cases also. So those cases are always difficult to manage. And these cases has to be managed with effective phaco-modulation, power, your fluidics, pressurized, IOP, everything has been modulated in a way where you don't change the anterior chamber dynamics during your surgery. Do a capsular access of a size around 5 millimeter, 4.5, do a hydrodissection delineation. During hydrodelineation, the capsule opened up. You can see this is a flutter happening and capsule opened up. In such cases, or cases where you have pre-existing open capsule, this chop and tumble technique is very, very handy and without disruption. The nucleus emulsification is complete now. I'll take out the epicortex, maintain the anterior chamber dynamics, don't let chamber to get shallow, aspirate the cortex. You can see the tear in the middle here, large tear extending from end to end, which is classically seen in a posterior polar cataract. This tamponading the anterior vitreous face and tear with the dispersive viscoelastic safeguards everything. And you can still manage put the lens in the bag in such cases. If you can able to manage the tear not to extend too much or anterior vitreous face not to get disrupted. So that's a very important teaching here to do a safe nucleotomy in these cases where you have the damaged posterior capsule. Same thing can be replicated. The layer by phaco or a crater and chop in a femtosecond laser. This technique we published way back of a femtosecond laser device where we make 3 rings of safety and 8 chops. And that gives you a layer by layer removal of these blocks, primary, secondary, tertiary block, and safeguard the epicortical cushion again. So this rings of safety and chopping gives very, very effective visualization of procedure. You can see the chops are there, no hydrodissection. Open this chop, the bubbles come out. Then you can take one by one each, you can say a piece, which is blocks we have made with the laser treatment. So laser is also a very effective tool in these difficult cases, challenging situations, wide cataract, subluxural cataract, posterior polar cataracts, and really change the entire concept. The posterior polar cataract, again I'll say, imaging is very important, pre, up, and post-op. If I have to do anterior segment OCT for my cases of cataract, I'll definitely do for all cases, but especially for posterior polar and wide cataract to see the morphology of these cases. And if you have a femtosecond device with you, these are also helpful in these scenarios also. Other area which most people neglect is the wound construction and its management during your surgery and towards the end of surgery also. This is what we looked into, compared femtosecond wound versus the manual incisions. And we realized that, if you do a nice management of wound, you have hardly any chance of a wound side Descemet detachment. But if you do a ragged incision, very dull blades, you can have Descemet membrane detachment in the wound area, and subsequently create a situation where like this. This is a Fuchs patient, and I'm completing my surgery in this case. Fuchs patient, you all understand, would have higher chances of Descemet membrane detachment during surgery, or subsequently also. And in such cases, it's very important to see carefully these patients also. So this is the aspiration. You can see little gutted changes in the central area also. I'm hydrating the wound. I realized that some flap was moving. I put on my IOCT microscope to see if this area is all right. Then I realized there's a little detachment in the posterior part. But as soon as I removed my cursor, took towards the central area, then realized it's a very large Descemet detachment. You can see how large it is. So this has to be managed on the table. You can't leave it for next day, which many people will do because they can't see this on the table. And next day, entire cornea may be white, and you do anterior-segment OCT, you pick up Descemet membrane detachment. So on the table, I could inject air bubble for 3 to 5 minutes, attach the entire area, and surgery was complete. So such disaster can be avoided if you can visualize the things on the table also. So sometimes microscope may not be able to pick up very, very clearly under the hydrated wound. So if you do a little bit of Descemet membrane disruption is there, do a hydration of wound very, very meticulously so that you don't increase the Descemet membrane detachment in these cases. To summarize, IOCT microscope can give you a same picture as you do with anti-segment OCT. So don't get that you don't have IOCT. Do anti-segment OCT, you can picturize all type of surgeries. It started with the posterior segment surgeries. We have translated 100% utilization in a corneal surgeries for this. As Prabhakar talked about, the corneal surgery requires the visibility much more than cataract surgery, and it is, has a nice application in cataract corneal surgery also. And in refractive surgery also, we have done a lot of work in this. IOCT is very helpful in these cases also. Wide cataract, showed you the intact gametes. Posterior polar, yes. So these are areas where I think IOCT going to be future application to all the surgical microscopes, and that is going to help you to assess your cases beforehand, plan your surgeries, modify your surgery intraoperatively, and come out with a good outcome for yourself and your patients. And like to thank you, all of you, especially the organizing committee of Andhra Pradesh Ophthalmic Society. This is my, I think, a 4th or 5th visit to Andhra Pradesh for various meetings, and I appreciate your help in a coming election for Vice President. Thank you for, again, wish you all the best.
Wish you all the best, sir. We all are there with you.